Hi, everybody. We're here in one more ECHO program on supportive care for chronic GVHD. I'm Dan Couriel, I'm the moderator. And our presenter is going to be Paul Carpenter, who pretty much doesn't need an introduction, but he's the director of long-term follow-up clinic and program, at Fred Hutchinson Cancer Center. And he's a professor of pediatrics at the University of Washington in Seattle, Washington. So this is the sixth ECHO program of the GVHD Interactive Provider Network. And the goal of this program is to connect GVHD specialists with community providers to share expertise, discuss cases, and improve patient care. ECHO stands for Extension for Community Healthcare Outcomes. You'll see that we have a didactic section and a case-based section that we've tried to integrate through today's presentation. This is intended to be of use for all health care providers. And you can read the educational objectives of today, 3 bullet points. And we'll start by looking at distinguishing GVHD supportive care from long-term follow-up care, and the importance of, the integration of both. Identify chronic GVHD supportive care options for different organ systems, and discuss how to provide supportive care for chronic GVHD, preventing complications and disabilities. So this is our agenda. Welcome and introductions, which we just did, and then we're going to follow with a didactic presentation with cases and Q&A discussion, and I have some closing announcements at the very end. These are our faculty disclosures. Please, I'm not reading them either, so take a few seconds to look at them. You have them for the chair, who's Steve Pavletic, the planner, moderator, which today is me, and then for our presenter guest, Paul Carpenter. Take into account that the GVHD Interactive Provider Network is administered by the Aplastic Anemia and the MDS International Foundation, and the partner organizations of the GVHD Interactive Provider Network are the Meredith Cowden Foundation and NMDP Be the Match. We will be recording this video, just so that we're recording it now, actually. And by participating in this program, you are consenting to be recorded, and we appreciate and value your participation. Sorry, I think I thought that we skipped a slide, but we haven't. These are some helpful tips for participating in the program. We encourage you to keep your camera on during the program. Mute your microphones when you're not speaking. If you need to ask a question, make a comment, raise your hand on camera, or use the icon, in the reaction section at the bottom of your screen. Please, when you do so, when you ask a question or give a comment, speak clearly and state your name and institution or practice before starting with your question or comment. And please feel free to use the chat function to submit comments or questions.
Hey, good morning, everybody. Hopefully you can see my slides. Thanks, Dan, for the introduction. All right, so this will be in 2 parts. The first part is the hopefully short didactic to introduce the cases, and the second part will be about the cases. I want to just draw the audience's attention to this paper from the working group on ancillary and therapy and supportive care for the chronic GVHD consensus project. That was from the second one of these consensus development projects, and this paper comes from 2015. And it was an attempt to catalog and define all of the ancillary and supportive care relevant to chronic GVHD. And it is very comprehensive, and obviously in the scope of this hour, we cannot possibly cover everything. So I've picked a few nuggets that will be highlighted in the case history. So the first question is, then, what is chronic GVHD supportive care? And as
Paul, excuse me, I'm sorry to interrupt, but your slides are not advancing. We didn't see the article reference.
Oh, really?
We're still on the supportive care
now?
for.
No?
No.
I don't know what to do because it's, they were advancing for me. What shall I do? I'll escape and try again.
There, okay. Now we're seeing the article slide.
So when I go to full screen, it doesn't work. So is this okay to just leave it in this mode?
Yes.
Okay.
We're seeing them now, so
okay.
Thank you.
So this was the paper that I was talking about. Hopefully so you can see the next slide, they're advancing.
Yes,
okay.
Yes.
So what is chronic GVHD supportive care? So in these NIH consensus documents, we defined ancillary and supportive care as the care which embraces the most frequent topical immunosuppressive or anti-inflammatory interventions, and any other interventions directed at organ-specific control of symptoms or complications resulting from GVHD and its therapy. And then also included in the definition were educational, preventive, and psychosocial interventions that had the same objective to control symptoms or complications resulting from GVHD and its therapy. And you'll notice in the third bullet that there are several important aspects of long-term follow-up care, such as monitoring and management of certain toxicities, for example, hypertension, hyperlipidemia, renal dysfunction, iron overload, and the list goes on, that were out of scope for those ancillary and supportive care papers. Now, that being said, we'll reframe that in terms of total LTFU care just in a few slides down. But to zone in on the ancillary and supportive care interventions, this is a summary of a very dense table in the manuscript that I referred to, and recognizing this table is also dense. But I want to just focus on the two right columns, prevention and treatment, and as they pertain to the first column of organ system manifestations, many of which we see in GVHD, skin, mouth, eyes, etc. And you can see that the prevention has a lot of focus on surveillance for malignancy, shown by the M in some of the latter rows, and infection. So we are always in ancillary and supportive care of chronic GVHD, making sure we don't have any signs of malignancy. And the key organs for that are skin, mouth, and female genital tract. And infection pretty much in any of those organ systems that we associate with GVHD. And then you can see there on the top of that, some of the organs have certain other things that we monitor. So in the eyes, for example, you're going to be monitoring for cataracts, intraocular pressure. Those things may be side effects of chronic GVHD therapies like steroids, but they can also be impacted by preparative regimen toxicity, infections, for example. On the right-hand side, you can see that focus on topical therapy. So in the skin, there's various moisturizers and other emollients. There's calcineurin inhibitor creams. You may consider wound care, wound cultures, sometimes antibiotics if there's infections on top of really infected-looking skin lesions. And then, worst case scenario, hyperbaric oxygen. So that's just a brief highlight at what you would see in the more detailed ancillary and supportive care skin table in that paper that I referred to. Just moving down as another example, whenever you've got GVHD of the liver, anything that inflames the liver, be it infection or GVHD, can be exacerbated by the presence of iron overload. So if you have transaminases of 500,000, well, if you didn't have iron overload, those transaminases may be a lot less. So sometimes with recalcitrant LFT abnormalities, you may need to address that iron overload if feasible. You can see now moving down to infection and immunity. Surveillance, as I mentioned, for infections, vaccinations are key, and then prophylaxis, antimicrobial prophylaxis, and judicious use of immunoglobulin therapy. And if you get an infection, then obviously there's going to be organism-specific therapy, and sometimes you'll need empiric therapy. We'll talk about musculoskeletal a bit more when we get to the case histories. Okay, so just zoning in a little bit on infection. Why is there such a focus on infection? In this large analysis led by Eric Chow and our group at Fred Hutch, in greater than 2-year survivors, you can see in this graph of incidence rate ratios that shown in the dark squares are the rates, the incidence rates of among transplant survivors, 90% of whom had heme malignancies, relative to non-transplanted cancer survivors, shown by the red circles, and all relative to the age-matched general population, shown by the line through 1, and that was from Washington driver's license analyses, similar to the other ones that Eric and his group have done. So there are about 5,400 non-transplant cancer survivors also in this Washington State Cancer Registry. And I want to just draw your attention to the fact that there is overall more infections in bacterial groups, fungal groups, and viral groups, but look at the vaccine preventable diseases shown in the last bar, where our transplant survivors have at least 10 times the rate that you see in non-transplanted cancer survivors, and about 30 times the rate compared to the general population. So that's somewhat sobering, and why there's such a focus on antimicrobial prophylaxis and vaccination. So these patients with chronic GVHD are considered to have functional asplenia when they've got active chronic GVHD in particular. They may have delayed numeric and functional immunity. So, low CD4 counts particularly can be seen in patients with chronic GVHD. They may have low B cell counts as well. They may have low immunoglobulins. Even if all of those things are normal, they can be functionally impaired by the immunosuppression that they're on. So preventive approaches include shingles prophylaxis, PJP prophylaxis, and encapsulated organism prophylaxis for all of our chronic GVHD patients on therapy, during that therapy, and for several months after. You definitely want to consider vaccinating them, or not, you should vaccinate them for SARS-CoV-2 plus their routine post-transplant vaccinations following national guidelines, or for the routine vaccines. This article, How I Treat article several years ago that I wrote with Jan England, can be quite helpful in going into a bit more granularity about how to do that. And I said judicious use of immunoglobulins. So I think the ASTCT Choosing Wisely initiative more or less says don't just treat the number. So just because your immunoglobulin level is less than 400 milligrams per deciliter, you don't just treat that number. And in general, I think we do follow that, but I don't think this Choosing Wisely initiative considered patients that we sometimes see with profoundly low immunoglobulins. So I'm talking about immunoglobulin levels in the 2 digits, especially if they have very low IgA level as well, indicative of poor immunoglobulin class switching. Most card-carrying immunologists would say you would replete those patients. So again, ancillary supportive care for the management of chronic GVHD is just number 15 on this sequential head-to-toe, what I call my list of approach to a patient with LTFU. You're always looking at an LTFU patient in organ-based, systems-based, and problem-based problems, 1 to 20 that I have here. And on top of that, there's a disease-based overlay. What does the patient bring to the table in terms of the underlying disease diagnosis? In this example, I use Fanconi anemia. And so you can see that there are the core elements of LTFU shown by the blue dots. And then there are these overlay elements. So a patient with Fanconi anemia may have ocular, ear, or oral abnormalities related to their underlying disease that are separate from GVHD or any toxicities due to conditioning. They may have congenital issues in these things, lens problems, deafness, genitourinary abnormalities, etc. And so you've got to integrate that. The ancillary and supportive care for chronic GVHD that we just talked about on the previous slides is all part of this big picture. But as you can see, as the example of iron overload, dealing with that problem can affect GVHD management as well. So the more you go into all of these little problems, you'll see more similar scenarios like that. So subsequent neoplasms is an important part of surveillance in chronic GVHD and general LTFU. I just mentioned the Fanconi patient who has an underlying cancer predisposition that we do not correct in their somatic cells other than our transplant. It's designed to cure the hematopoietic system, but they have a higher risk of skin cancers, oral cancers, and other cancers, for example. And then now you've got on top of that the potential chronic tissue turnover in the mouth and the skin with chronic GVHD that's poorly controlled, and that can exacerbate the risk for skin malignancies. And then add on top of that the conditioning regimen or any other chemotherapy they had prior to coming to transplant. In this large analysis led by Scott Baker from our center, you've got some hazard ratios relative to chemotherapy only as the reference point, which if you've had chemotherapy only preparative regimen, you've got about a twofold risk of subsequent neoplasms relative to your age-matched peers. And then it's not until you go above 450 centigrade of TBI that you start to see significant impact of various radiation doses in escalation. And note this historical single fraction TBI really ramps up the rate of subsequent neoplasms. Fortunately, no one does that anymore. But this just does highlight in general why it's so important to do surveillance. Here's just one slide on iron overload, where in the autologous transplant setting, the 5-year cumulative incidence is less than 1%, but in the allograft setting, it's about 25%. And among those patients with allotransplant recipients, about 32% of them in one study had significant liver iron content as defined by more than 1.8 milligram per gram of estimated dry hepatic weight. So for the patient with ferritin not too high, with a low or normal percent transferrin saturation, you may just have the patient avoid an iron-containing multivitamin. You could add phlebotomies if the ferritin was high, especially if the transferrin saturation is more than 50%. And if phlebotomies are not feasible because their hematocrit or their hemoglobin is, say, 10 or 9, you might be able to facilitate that by boosting their hemoglobin with erythropoietin shots. Now, in certain diseases, like a heavily transfused bone marrow failure syndrome patient, or especially the hemoglobinopathies, generally it's recommended to be more aggressive with iron overload management because of their risk for late effects like cardiac failure and iron overload in other organs. And so sometimes you try and start this at about 6 months post-transplant, where you may need iron chelation as well as phlebotomies, recognizing that iron chelators can sometimes be problematic in patients on some of the immunosuppressive medicines. And it's often helpful, particularly in these higher risk groups, to monitor their liver iron content more formally with a T2 MRI, given that ferritin assessments can be affected by inflammatory conditions and GVHD per se. Last slide of the didactics is just to bring home the fact that long-term follow-up and these late effects have a latency period of 7 to 20 years for many of them. So it's really important not to lose these patients into long-term follow-up, which is a big problem with the premature termination of long-term follow-up, especially among younger patients who appear to look well at, say, 2-3 years post-transplant, and then they get told, well, we don't need to see you again because you're doing so well. But just keep in mind this latency. Keep in mind all of these negative impactors on the late effects, GVHD obviously being one of them, infections, medicational toxicity, and these are the post-transplant complications. And then the pre-transplant exposures that we talked about, conditioning, chemotherapy and radiation that they may have gotten before they came to transplant in cases of underlying malignancies being the disease indication for transplant. And then what do they bring to the table in terms of their underlying disease diagnosis? We mentioned Fanconi anemia, but there are others, obviously, particularly in the pediatric realm, diamond black band anemia, Wiskott-Aldrich, the list goes on. And then on top of that, some things that can be plus or minus in terms of how they affect late effects is this genetics, the age of the patient, the gender, and lifestyle. And with that, we are going to move into the cases. And the first case I'm going to present, and then my moderator is going to present the last three cases. This is a one-slide case presentation of a 29-year-old male who had a matched unrelated donor peripheral blood stem cell transplant for T-cell acute lymphoblastic leukemia. Fast forward to 8 months post-transplant, where this patient is being treated for late acute GVHD of the skin and gut. And at this point, they're just being treated with topical gut steroids, budesonide, and their tacrolimus dose was increased slightly, but not too much, recognizing that the patient was also being treated with voriconazole for fungal pneumonia. And I want you to keep track of the timeline here from 8 months all the way to 28 months. At 19 months post-transplant, we've now got some classic NIH chronic GVHD manifestations in the mouth. So now we can declare them with chronic GVHD. They still have their late acute GVHD flaring, and this is occurring in the liver, having already tapered off tacro somewhere between 8 months and 19 months. So at this point, the patient was started on dexamethasone oral steroid rinses and oral beclomethasone for the first pass hepatic effect to try and deal with these kind of mild transaminase elevations in the 100 to 200 range. 2 months later, the patient is appearing Cushingoid, and note that they've only been on topical gut steroids. They've got, for the first time, a recording that their range of motion, so this is the PROM, photographic range of motion scale, has dropped by 3 points. And what they're mainly limited with is shoulder abduction. They've lost a point or two off each shoulder. And so somebody diagnoses them with fasciitis of the shoulders as well and starts them on prednisone, 20 milligrams a day. 1 month later, they've got increased liver function tests again. Their joint pain seems to be improved. And for the problematic liver function test, the prednisone is escalated. They restart tacrolimus and ursodiol is added. 1 more month later, somebody has requested doing pulmonary surveillance, and we see that there's significant obstructive changes in the PFTs that are developed, with the FEV1 down to almost 49%. And the FEV1 FVC ratio is certainly less than 0.7. They have the question is whether they have new bilateral shoulder sclerosis. They have stable oral and resolved liver GVHD. So restarting tacro and increasing prednisone helped those original manifestations in the first column. And they started on FAM therapy and long-acting beta agonists for their new bronchiolitis obliterans syndrome diagnosis. Note that the patient's still on voriconazole at this point. And then 5 months later, the patient comes to see me for consultation for a second opinion. And the chief complaint of the patient to me was tight shoulders and left hip pain. The patient had told me that he'd had an outside PT consultation who had diagnosed possible frozen shoulder. I saw the patient and noticed that he was extremely Cushingoid by this point, with these features listed here: buffalo hump, stria, ruddy face, and acne. The range of motion was about what it was at the 21-month mark. But what I noticed on exam, I didn't see any signs of sclerosis. There were no groove signs. There was no dimpling or skin dyspigmentation. I couldn't find any sclerosis anywhere. And then the PFTs were repeated, and they were about similar, so stabilized on the FAM-LABA therapy, and the liver function tests were normal. So I concluded that the GVHD was mostly stable on a dose now of 30 per day. Budesonide was still going, all the way back from 8 months, and they're on tacro. So what did I advise? And I'll stop there and open this for discussion. Who can I see in the audience there? Can I ask Iskra to comment?
Knew it was coming.
You're the first person in the line.
Oh, Iskra, come on.
Good, how are you? Well, great presentation. So what did you advise? So clearly, it seems to me that this person is still on a decent dose of steroids, and that we should try a way to decrease prednisone dose. As you said, he doesn't have any sclerosis, but what he's on could be somewhat tweaked. So one thing that we have had some luck in the past was that this time, for these patients who have been on tacrolimus for a long time, possibly taper tacrolimus, and you could try him on sirolimus. And sometimes we have seen that that allows a little more activity of Tregs. So that could be maybe the first step. And the other would be to initiate one of the newly approved drugs, possibly in this case, since there is no significant sclerosis, we could try either ruxolitinib or probably ruxolitinib at this time, but then keep in mind that there have been reports of Resrock. I'm now blocking the valumocidil, improving people who have lung GVHD with lung fibrosis. So these are some potential.
Yeah, so those are, I mean, those are obviously really good suggestions if you were convinced that this was GVHD that was not responding. I guess, it's very hard in like this one presentation where you don't have the patient and, I just put you on the spot there. So in terms of thinking about these things, I mean, I guess my conclusion was that this patient really didn't have active GVHD. And, again, I tried to sort of, I don't want this to be guess what I'm thinking, but like what I was struck by when I saw this patient is they've had 20 months of voriconazole therapy and topical budesonide and beclomethasone for a long time. Then it's not until later on that the prednisone was added. And why was this patient so Cushing rate at 21 months with just topical gut steroids? And one of the things I think is an important take home is that these topical steroids, their systemic steroid exposure that we tell patients is, well, this is why we're using these drugs, it's not so bad. That just goes out the window if you're on voriconazole or something like that. And so this patient has had a lot of systemic steroid exposure, which worried me a lot. And then when I saw the patient, the chief complaint was tight shoulders and left hip pain. I was thinking, well, and then I didn't see any sclerosis. I didn't see anything that looked like the patient had sclerosis or even fasciitis. The rest of the range of motion at the hands was fine. That just seemed unusual to me. So I was worried about that we had created a toxicity here that might have been accounting for the shoulder problem. And the PT, wondered about frozen shoulder. I was actually thinking about, well, does anyone else have any thoughts and Iskra, what do you think now with that extra information? If it's not GVHD, what are you worried about anything else?
I mean, he could have avascular necrosis, and maybe it's the steroids, and that would worry me. The main reason why I was advocating for possibly escalating immune suppression was his PFTs, not so much the tight shoulder. Yeah. The tight shoulder I would do more workup and probably send him for the MRI and try to evaluate whether there is something else going on with hip and shoulder.
Yeah, no, the PFTs are absolutely super concerning, right? I mean, something happened before 23 months where those PFTs plummeted, right? And it is a problem, that he did not have PFTs between 8 months and 23 months. That's going to be one of the hopefully take homes from this case. So I totally agree with you, and you're very worried about the PFTs. I was super worried about the PFTs as well, but just in dealing with his chief complaint, that's what I think. I do think he needed imaging. So we went on and got some imaging, and he had horrible AVN of both shoulders with collapse of the humeral heads. And he had early AVN in the left hip. So as far as the GVHD of the lung, we did send him to the pulmonologist, and I think their conclusion was that he had stabilized, and we essentially had missed the boat, right? Because he's lost a lot of FEV1, but it had stabilized, and so 23 months to 28 months, his FEV1 is essentially the same. And his air trapping hadn't gotten any worse. So nothing was done other than I tapered prednisone, got him off prednisone, and he's actually now had bilateral shoulder surgery.
And I'm sorry, maybe I missed, did you say, was he at all symptomatic from his lungs?
You know, only mildly. I think the reason he was not that symptomatic was he wasn't doing much because he had so much limitation from his end. But yeah, you're right. You would expect him to be starting. It's certainly, I mean, you can lose a lot of lung volume, but usually at that point you would expect something to be symptomatic. I would agree. Does anyone else have any questions about the case before I just show a few follow-up slides on this particular?
Yes, Paul, Kirk Schultz had raised his hand.
Kirk, yeah.
Well, I guess I think you've touched on a lot of the things that, but I guess I would just add in that I would argue that if you're going to continue with any kind of drugs, that tacrolimus is not what I would have considered an optimal drug in this setting. And I agree with Iskra that even though you've got, and I've got some of these bad AVN patients, and because they got overtreated, and then you finally see them and it's like, oh my gosh. And so you're trying to spare steroids, but I think belumosudil seems to have really good activity in lung GVHD of all the agents we have available. And I think a switch to that to try to see if you get impact on the lung function would have, anyway, that's where I would have also gone.
Yeah, I mean, I think what you're raising is a really good point, is how much of the lung stuff is reversible. I think there's two ways of thinking about lung GVHD, right? So what is the trajectory of their FEV1? Definitely if the trajectory is going down on whatever treatment you're on, you need to change the therapy. And, yes, we are using more of those newer agents in lung GVHD that's getting worse. I think that in general, our pulmonologists don't make us change therapy if things have stabilized on the inhaled mainstay of therapy, which is the FAM-LABA. I'm not aware of data that these drugs can reverse the fibrosis that's already there or the scarring, but that's an open question, right? There's some of these drugs like pirfenidone, which they have also pulled out. I don't know that the data on that is great. I know Kirsten Williams is interested in one of the newer drugs, which I can never pronounce the name of, Natanidib, is that what it is? It's another one of those antifibrotics. But I think that's the question, Kirk, is this reversible what's there now? If the patient was getting worse, we would definitely change therapy. But mostly what this patient needed was so that they could go ahead with their orthopedic surgery to get way down off of the steroids.
And I'm also curious what kind of surgery you did on the shoulders that improved function.
Joint replacement.
So you actually did joint replacement. Okay, interesting.
Yeah, because there was not. So we can talk about that. That's a really good point, though. But first of all, just the monitoring is super important. And this is the photographic range of motion scale for those who are not familiar with it. You're basically doing, these are the pictorial representations with these sevens being full range of motion, 7 out of 7 for shoulder abduction, elbow full extension into lockout, and then the namaste prayer position, 7 out of 7 is full. And it's just a 4-point scale for dorsiflexion of the foot. You add these up and get a score out of 25. And this has been done in 2 prospective studies. The second one, led by Yoshi Inamoto, is published in Blood Advances, and a 2-point total change is clinically meaningful in either direction. So here's just another patient showing abnormal wrist finger. So this is the namaste position, which is abnormal here. And after therapy, it was starting to improve. But in my patient that we just presented in the case, this was the range of shoulder abduction problems shown in this 5 and 6 up here. So pretty limiting. Our approach at Fred Hutch to screening for bronchiolitis obliterans and monitoring recognizes that about 1 in 4 patients develops post-transplant airflow obstruction, all of which is not necessarily irreversible. Yet, if you get this scenario, you have to consider bronchiolitis obliterans whenever there is irreversible airflow obstruction. So sometimes you need to do at least 1 test with and without bronchodilators to confirm that. And the prevalence of this is about 5 to 6% after transplant. But that increases to about 14% among those with chronic GVHD. And just to close the loop, about 1 in 3 patients with chronic GVHD develop airflow obstruction. So I've just thrown at you 4 different statistics. 1 in 4 develops post-transplant airflow obstruction that may or may not be reversible. 1 in 3 with chronic GVHD develop airflow obstruction. And then if you now nail it down to bronchiolitis obliterans with irreversible airflow obstruction, it's about 5 to 6% after transplant, increasing to about 14% in those with chronic GVHD. So this is what informs our pretty aggressive PFT monitoring, which now happens in all patients with allotransplant at 3 months, 6 months, and then annually for 5 years post-transplant, or until children reach final adult height, or 5 years post, whichever occurs later. And then if you're diagnosed with chronic GVHD of the lungs, then you get 3 to 6 months spirometry at least once that GVHD is being diagnosed, until 2 years after stopping immunosuppression. And so you can see in our patient that had we picked things up earlier, maybe we could have presented that by earlier introduction of the therapies. Just as far as the AVN goes, we've got low bone mineral density. That's part of our musculoskeletal health. So you're looking for DEXA scans, monitoring their vitamin D and calcium intake, all of that good stuff, and then optimizing those things where possible. In patients where gonadal hormone is appropriate, you can give that, and that helps bone mineral density. And then for the people where that's not appropriate or insufficient, bisphosphonates and other neuroagents should certainly be considered. In avascular necrosis, this is less common than reduced bone mineral density. It's usually glucocorticoid related, increased in those patients with sickle cell disease. The case is very illustrative of what happened, and the MRI is the most sensitive way to look for this. If it's advanced, you can certainly pick it up with plain films. You're going to refer them to orthopedics. If the patient has pre-collapse AVN, not what my patient had, sometimes bisphosphonates can help stabilize that. There are some small randomized studies suggesting that. And this paper that we developed through ASTCT, led by Marav Bah, does summarize bone health rather comprehensively for those who are interested. All right, and then from the supportive care paper that I referred to in the beginning, and this sort of gets to Kirk's point, this was a young male, but it's sort of, you would behave, I think, similar to a child. The major goal is actually to avoid early joint replacement because they have a finite lifespan. However, this is really in the purview of orthopedic docs who have experience in these patients, and sometimes these temporizing measures are insufficient. If, for example, in the hips, I've seen core decompression sometimes be helpful in hip AVN early, and that may move further down the line, total hip replacement or hip resurfacing. But you really need to work closely with trained orthopedic specialists in this. All right, Dan, next case.
And we have 20 minutes. I hope that we can finish the 3 cases, but let's present this one swiftly. The case 2 is a 66-year-old patient with match-unrelated donor transplant for MDS. He has a history of hypertension. He had a relatively uneventful transplant with moderate tremors, mild renal dysfunction on tacrolimus, and he's no longer on his 2 antihypertensive medication. as of the period that goes between day 0 and day 100. He presented on day 270 with dry mouth, dysgeusia and sensitivity to spice. And he was started then on prednisone 1 mg per kilo plus sirolimus. And this was, after a diagnosis, of course, of chronic GVHD of the oral mucosa. The prednisone was tapered off 2 months later, and he was continued on sirolimus, kept at levels of 7 to 10 nanograms per ml. He did not have any other lab monitoring. And then 14 months post-transplant, that's a few months after he was off the steroids, but still on sirolimus. He presents with severe headaches, acute chest pain, radiation to his left upper extremity, a blood pressure of 190 over 115, and an EKG, and troponin suggestive of an MI. Triglycerides were 800 milligrams per cent, and total cholesterol 320 with an LDL of 200. So the question here, and I'm going to open it for discussion, is was the MI on month 14 post-transplant potentially avoidable? If so, how? What happened here? And then after we discuss this, I think that Paul is going to let us know how common cardiac complications are in transplant survivors. So I'm opening this for discussion. Could we have avoided this, and how? So I encourage the audience, otherwise I'm going to ask the question to Paul. For the sake of time, Paul, how would you have handled this in a more proactive way?
I mean, I think when I'm picking immunosuppressive therapy for chronic GVHD management, I'm going to definitely also look to the family history and the patient's prior history. I mean, is this someone who came to us with metabolic risk factors? What was their fasting lipid panel before transplant? What was their blood pressure? What's their family history for some of those cardiovascular risk factors like early heart attacks, age 40 or earlier, stroke, diabetes. If any of those things were positive, I'm not sure sirolimus would have been my first choice agent. But if I did use sirolimus, and I certainly like using sirolimus, I would be managing their hyperlipidemia that can be exacerbated by that medication. And that blood pressure is impressive. Now, that could be in the setting of the acute event, but you've said at the beginning the patient has a history of hypertension. So he's no longer on his antihypertensive medications in the first 100 days. Well, why is he not having that addressed beyond that time? And even within 100 days, it's my practice to manage their hypertension. So I do think this patient was set up for problems, and the triglyceride level of 800 is pretty sky high too. You're risking other things too when it gets that high. Pancreatitis is another potential risk factor when it gets very high. So I would be wanting to manage their metabolic risk factors based on some of the data I'm going to show you on the next slide. Is that what would you add in addition, Dan? Or
that is exactly what I was gonna mention. I mean, there were a lot of things gone wrong here, right? But also the message of let's not forget that there are things that are not directly transplant related that can kill some of these patients with the right set of risk factors, correct? Which is what happened here. I mean, there was no sufficient consideration of the fact that of all the things that you very nicely outlined, right? This was a high-risk patient, and And well, people that have a transplant also die of common causes, right? So let's not forget that. And that's all I would have to add. Thank you.
Yeah, and this sort of, again, it shows that the link between integrating ancillary and supportive care, where what we just talked about then was out of scope of that, but it needs to be considered within total care of the patient on these medications. So just looking quickly, this is from a book chapter that I recently wrote. On the left-hand panel, you can see that deaths due to cardiovascular disease with 10-year and 30-year cumulative incidences are in the sort of 3 to 4% range. Congestive cardiac failure is sort of 7 to 9% range, and the subscript here says that that is increased in certain higher risk groups. The younger patients, what was their anthracycline dose, chest radiation, hypertension, diabetes, and smoking. And so you can see moving down the list here, there's a high prevalence of metabolic syndrome defined by some of these metabolic risk factors and increased abdominal girth. The incidence or the prevalence, the 1-year prevalence, period prevalence is about 60% for hypertension, and 10-year cumulative incidence about 40%. So these are important risk factors. And then in this nice analysis by Eric Chow on the right, you can see the blue symbols versus the yellow symbols. Blue symbols are, the yellow symbols are adjusted for sex, non-white, age, and BMI, but before adjustment for the blue symbols, which includes smoking, current smoking, daily fruit and vegetable intake, and recreational physical activity time. But you can see all of these factors here: cardiomyopathy, stroke, hypertension, dyslipidemia, and diabetes are in general greater than the general, population. The ischemic heart disease is a little bit lower, but there's selection bias in who comes to transplant. That's not to say this is not an important problem. So just moving on to the next case, Dan, do you want to do this one?
Sorry, I forgot to unmute myself. The third case is a 41-year-old female who had a match-related peripheral blood stem cell transplant for Philadelphia negative ALL. The first 3 months were complicated with acute GVHD of the skin, grade 2. 9 months post-transplant, she is off immunosuppression. And 11 months post-transplant, she has worsening dry eyes, very mild oral dryness, and she started herself on preservative-free artificial tears, which she needed 20 to 30 times a day. She was sent to the ophthalmologist that diagnosed ocular chronic graft-versus disease, and at that point prescribed cyclosporin eye drops and plugged her lacrimal ducts. This is 11 months. 3 months later, 14 months, the eyes are worse. So she's given prednisolone eye drops by ophthalmology. At 16 months post-transplant, it's 2 months after initiation of prednisolone. She has severe bilateral ocular pain affecting her vision with dryness and redness. And the ophthalmologist finds punctate keratopathy and cicatricial conjunctivitis. So the questions here, I think, are, was there a better way to address this patient's ocular chronic GVHD, which is so like everything else in transplant, but so time sensitive and very much irreversible in its most severe forms. And how would you have managed the case if this was your patient? What role does systemic immunosuppression play? And do you think that, a long time, went by from 10 months post-transplant, 16 months, so 6 months of what kind of symptom management do you think, or symptom relief do you think this patient had? Was symptom management adequate? Those are all questions that I think come out of this case, right? So
Exactly.
I want to let the audience and discuss, and certainly Paul, you can actually discuss whenever you want.
Anybody want to chime in, or shall I just talk?
I mean, I can just say is that it seems obvious that the symptoms were not managed adequately, since this person had severe pain and really needed to use the eye drops often, and seemed like she had quite minimal relief from physical therapy, really, that she has gotten. And I had kind of a similar patient who really had some minimal skin GVHD and primarily had involvement. And we started her on systemic therapy. And in her case, it was with ruxolitinib, where she relatively quickly, I mean, for sure in the first 3 months, had severe, improvement, a kind of impressive improvement in her symptoms, and eventually it kind of her symptoms reverse. Her eyesight is now completely normal. She doesn't she used minimally artificial tears, and she's essentially symptom-free. Her sclera has healed, and it has been now years that she has been actually off any systemic therapy, with a complete reversal of her eye GVHD.
Yeah, I think that's, I share a similar point of view. I think the time to be aggressive with new onset dry eyes that you're attributing to GVHD is in the beginning, because once too much damage has happened, the patients are left with burnt out ocular sicca, and the GVHD manifestations in other organs can have gone, but you're still just left with dry eyes. So certainly when we've been talking with treating ophthalmologists who see these patients a lot, that's the message that I've gotten. And I think even if you wanted to try ancillary therapy, which I don't think is wrong, if that's the only manifestation, I probably think our ophthalmologists would have used the steroid drops very early, not all the way down here from 11 to 14 months. But I think the take-home message is, if the signal is really not working, and maybe they needed a shorter follow-up between 11 months and 14 months to say, well, it's not working, we need systemic therapy.
Totally agree. And actually, at 11 months, when a patient presents that way, immunosuppression, systemic immunosuppression should not be a second thought, because that's when, you have the potential of at least reversing partially your problem.
Yeah, and I agree. And the ancillary and supportive care paper kind of speaks to all of these things that were tried. But in the text, I just want to draw your line, highlight that the bottom paragraph says, when the sole manifestations of chronic GVHD are ocular, systemic immunosuppressive therapy may be needed to be initiated or resumed when topical and other local measures are insufficient to control the inflammation and symptoms. Now, obviously, the devil is in the detail there, and it doesn't say how long to try the topical immunosuppressive therapy, but that's the point of presenting this case. I think, there is a bit of an art. How long do you wait? But I think the consensus from at least those of us on the call here is to be aggressive early with the systemic immunosuppression if it's not working, and close follow-up is needed, not 3-month intervals for that. We have
and I think that somewhat it becomes easier now when we have more therapies available that are less generally immunosuppressive. I mean, we can always try a course of systemic steroids, but we have newer treatments that are not so systemically immunosuppressive, and we might kind of easier go up front with these drugs and try them.
Yeah, it's a possibility. I mean, doing a clinical trial to address this question is very difficult, right? Because it's not common that we have isolated ocular sicca as the sole manifestation of chronic GVHD. Usually it occurs with some other things. So finding enough patients that just have ocular GVHD to doing the trial to answer the question in a scientific way is likely not going to happen, I think. So you just have to make a judgment call about what toxicities are acceptable to the patient if you want to try something else versus a pulse of prednisone, for example. But whatever it is, I think systemic therapy should be initiated sooner rather than later.
Agree.
I'm not sure. So we've actually gotten through 3 cases, which is more than what I've seen on some of these other.
Alice is telling me that we can go over a few minutes if you want to.
Okay.
Since we have you in on the call, and you truly are a world expert in vaccination. I don't want this one not to be presented, because I'm sure that just like me, everyone wants to hear your opinion. So this 4th case is a 49-year-old gentleman who had a match unrelated donor BMT for AML with a long-standing history, years, of chronic GVHD, oral chronic GVHD. The oral symptoms have been maintained stable on low-dose prednisone and dexamethasone oral rinses as needed, but he's never able to taper the pred below a 5 milligram every other day dose. He comes in for COVID vaccination today, 3 weeks after his 2nd dose of an mRNA vaccine. And he presents with worse oral symptoms with marked buccal oral erythema, bilateral oral ulcers, lichenoid changes, more than 50% of his oral mucosa versus less than 25% last month. What do you think happened? Paul, how do you manage COVID vaccination? And maybe you can mention other vaccines that are not mRNA vaccines, in patients with active chronic GVHD or chronic GVHD requiring immunosuppression. So I want to, let you comment on this directly for the sake of time.
I mean, I think this is the conundrum that we've faced throughout the pandemic. And as you know, there is increasing herd immunity. We talk about this more. In the beginning, like it was just, our infection prevention people were saying vaccinate, vaccinate, vaccinate for obvious reasons. And our policy is to start vaccination at 100 days post-transplant, 90 to 100 days post-transplant in all of our transplant recipients, trying to get that primary series in. Now, everybody, as soon as people get vaccines, particularly the one that's as potentially polarizing in the public as COVID, they want to say, well, if a GVHD, something bad happens within some time frame after the vaccine, that it potentially was caused by the vaccine. And before we had COVID and before we had the pandemic, we gave lots and lots of vaccines. Patients would come in for their annual follow-up, they'd get 7 shots. We did that all the time. And, rarely does someone have anything more than a local reaction. Occasionally you get that 1 in 5-year patient with Guillain-Barré, and is it the vaccination? I think we are seeing case series and case reports that's raising some concerns, but recommend, just caution people to say that there is reporting bias of small case series. And the 2 larger retrospective reports that I can find with, over 100 patients, they are retrospective. And they see, so there's one from City of Hope on the left and one from Europe on the right, where about 40% of the City of Hope cohort had chronic GVHD patients when they were vaccinated. 4 of those 113 worsened their chronic GVHD, and 11, or around 10%, had new or worsening chronic GVHD within 60 days of the shot. In the European scenario, about 25% of patients had chronic GVHD at the time they were vaccinated. 10 of that 167 got worse, so that's about 6% within 80 days of the shot. And 9 of 41 with the chronic GVHD, that's a bigger percentage, had worsening. But the point I think that's important in that series, at least, is that 9 out of 10 of those patients who got worse were on immunosuppression for smoldering chronic GVHD, or they were tapering their immunosuppression for controlled GVHD. So part of the conundrum when listening to these reports about things happening after COVID vaccination is, what was the trajectory of the patient's GVHD at the time they got their shot? And were they tapering? I mean, there's plenty of patients, right, pre-pandemic who were tapering immunosuppression and they'd flare their GVHD, and we didn't have to invoke anything other than they were tapering. So what do you do with these data? I think our approach is to counsel patients, but mostly we proceed without modifications. We did go through a phase where we thought as a group, well, maybe we should avoid tapering their immunosuppression around the time of vaccination. But then that leads to the question of how long. Are you going to do it for the entire primary series, which could be several months? I think you need to prioritize the risk versus benefit. So you really should get that primary series in around day 90 to 100 post-transplant. And then I think as the pandemic potentially wanes, that risk benefit may change. And just as a simple analogy, when we had eradicated polio and we were using the oral polio vaccine because it was easier to administer, then that 1 in a million risk of having a polio-like illness from the oral vaccine became unacceptable, and hence the oral vaccine went out of, it's no longer available in the US. So, we may see a point where we have to think more cautiously about these flares. So in general, I give the vaccines, although I will tell you just this week, I deferred the COVID vaccination in a patient in their mid-20s who had an unusual presentation of a GVHD with massive serositis and cytopenias. And they were just getting those under control. I had the patient on MMF, and I've taken away the calcineurin inhibitor, and I'm not going to give them the COVID vaccine just yet because, that is potentially a confounder. So I don't think there's a one-size-fits-all answer, but in general, I would proceed with the vaccine. But I'd be interested to see what others have to say about it, because I don't think anyone can claim to be an expert on this. We're learning. We just need larger studies, and we need more details about the immunosuppression and the trajectory of their GVHD at the time they get their vaccines.
Yeah, I told you we had a rapid communication to BMT last year, and what we submitted, it was probably half of the patients that these series that you were showing had, like 50 something or 50 patients, and about a third of them, had reflare, and none of these were on any taper. So they were on stable immunosuppression. They were mostly patients that were treated for chronic GVHD without active or very active symptoms or more than mild symptoms. But I think that there's something to be said about the type of vaccines, right? Because with as many vaccines as we give, I think this mRNA, the mRNA vaccines are a different animal, right? In terms of immunogenicity. What do you think?
Well, I think they are far more effective, and that is potentially true. I think when the shingles vaccine came out, that was also a vaccine that was, highly reactogenic, and we had some theoretical concerns about giving that. But the Boston group showed very nicely, with some sort of historically controlled data, at least, that they didn't see an increased signal for GVHD, and they were giving that vaccine as between 9 and 24 months post-transplant, if I recall correctly, and that was in a fairly large series. So I think, the mRNA vaccines may be different, and certainly we've seen a few cases of, more florid GVHD reactions with, fluid effusions and things that seem to be a little bit beyond the norm. And yes, they did occur within, several weeks of the COVID shots, but it's sort of hard to kind of, well, what is your window for causality and the association? How much of a time window are you going to expect? Are you going to say is more likely to be a COVID vaccine phenomenon or not? I really do think you just need a much larger analysis and a more detailed analysis to get at it more clearly. But I do think the risk to benefit will change over time. And the patient that I just talked about, we're in the middle of a flu epidemic, and I gave the patient the flu shot. So just because we haven't seen those same sorts of reactions other than local reactions. So, I don't think there's one right answer, but you don't want your patient to get COVID without any immunity either. So it's weighing the pros and cons. And that is, I mean, the last slide of vaccines is, just the up-to-date potential use of Prevnar, but most of these other vaccines we've been giving to all of our patients. So I don't really have much more to say. That was the last slide. And we've gone over. Thank you for everybody who's stayed.
Then there is an on-demand webinar coming, a quality of life pre and post transplant, the role of transplant for treating MDS in older patients, sponsored by NMBP and the Plastic Anemia Foundation. Also the Meredith Cowden Foundation, GVHD 2022-23 National Symposium Series on Friday, January 27th. Joseph Pidala from Moffitt is going to talk about how to choose drugs for chronic GVHD. I hope we're all there.